Hello, my name is Michael Postiga. I am an interventional pulmonologist at the University of Kansas, and today we will be talking about percutaneous dilation tracheostomies. Most percutaneous tracheostomies are done using a blue Rhino kit. This is a picture of the G2 blue Rhino kit. That is the current tray that I have in my own institution, and you probably are going to have it in your institution. You should be familiar with the instrumentation that you have in this kit. This is how I set up my tracheostomy kit to ensure that my instruments are always readily available. I will place the kit on a regular ICU working table and use the folding drape from the kit to create my sterile field. In addition to my tracheostomy kit, I will also use a package of sterile surgical towels. When arranging my instruments, I will first place the surgical drape and the sterile towels in the right hand corner. I then place everything that I will use to access the trachea at the bottom of the table. This will include a ChloraPrep that I am going to use just before I start the tracheostomy, lidocaine with epinephrine that came in the kit, and the important thing is the epinephrine that is going to slow the bleeding, a scalpel, a curved Kelly's, a introducer needle. Next to my drapes, I will place my guide wire. I will make sure that is ready to be used. Also, I'm going to have a 6cc syringe that also comes in the kit that will help us to inflate the trach balloon. Also, I'm going to place the inner cannula in that area. On the left side of the table, I will arrange my tracheostomy, my trach. Actually, I normally use a Shiley. I normally use a Shiley 6 for females and a Shiley 8 for males. If for some reason there is a female that is 6 feet, then you will just switch that, and the same thing if you have a male that is very small, you can consider placing a 6 instead of an 8. But for the most part, 6 for female and 8 for males. Also, I'm going to have your punch dilator, also well looped. And finally, in the superior part of the table, I will place the instruments that I am going to use to secure the trach when you are done with the dilation part. That will include another ChloraPrep to clean the tracheal area after the procedure. You're going to have your sutures, your needle driver. Also, I'm going to have several 4x4 available throughout the procedure. In addition to the instrumentation that we just reviewed, it's also very important the people that are going to be helping us throughout the procedure. So in this picture is a representation of what normally happens in the ICU room where we are performing the tracheostomy. Labeled as number 1 is the person performing the per trach. Usually is in the right side of the patient. Number 2 is the bronchoscopist, situated at the head of the bed. On his left side is going to be someone handling the endotracheal tube. I usually use the respiratory therapist to do this job. And labeled as number 4, we have the representation of the bedside nurse. She will have a key role throughout the procedure. She will be monitoring the vital signs and also it's going to be titrating the medications we are going to be using throughout the procedure. Normally we perform this procedure on propofol drip, and we use some Versed and fentanyl as a PRN doses, and I will also routinely use paralytics except when they are contraindicated. Positioning the patient is super important for this procedure. So we will hyperextend the neck in order to make the landmarks that we follow a little bit easier to palpate, and also to have a little bit more space to perform the per trach. Also, I make sure that the patient's shoulder and hip are well aligned and the head is midline. Okay, so up to this point we have discussed how to prepare to do the per trach, but now let's move on and discuss the actual procedure. So the first step will be figuring out the landmarks. Here my first line represents the thyroid cartilage. My second line represents the cricoid cartilage. I am marking the lower border of the cricoid cartilage, and below that line the other inverted triangle represent the sternal notch. I am going to make my incision a couple of millimeters below the lower border of the cricoid cartilage. Okay, so the next step will be cleaning and making our sterile film. We're going to use a chlorhexidine as a regular procedure that we do. I use the blue towels, the surgical towels, to make the sterile film a little bit bigger, and then as you guys can see, I am using the pre-cut sterile drape that come in the blue Rhino Kit. I'm getting ready to inject the lidocaine with epinephrine. As we talked before, the epinephrine is super important here. It's going to help us with vasoconstriction and decrease the chances of having any significant bleeding. I am going to use the 10 ml of lidocaine. After that, I am going to perform a 1 centimeter horizontal cut. I make sure that this midline, as you guys can see, I am palpating and making sure that my landmarks are correct, and I'm still midline. My technique with COVID have changed a little bit. Before, I will have the bronchoscope already in the AT tube, and the AT tube will be withdrawn to the level where we were going to make our cut to have an extra safety net. However, with COVID, we are performing tracheostomies under apnea. So at the time that we introduced the bronchoscope, the patient got completely apneic, making the incision before save a little bit of time. So as you guys can see right now, I just made my incision. Your incision doesn't need to be super deep, just to go through the fascia. Then you use your curved Kelly's to do a blind dissection, and then I'm going to introduce a finger to make sure that I don't palpate any vascular structures. The next step after we make our incision and make sure that there is not any vascular structures that are palpated is withdrawing the AT tube to the level that is desired. So that level is a couple of millimeters above our incision, pretty much at the level of the cricoid cartilage. In order to do that, what we're going to do is ask our bronchoscopist assistant to introduce the bronchoscope really quickly extend beyond the endotracheal tube to help us figuring out the anatomy of the trachea. We are especially focusing on what is the anterior portion of the trachea and posterior portion of the trachea. We are trying to make the entrance of the introducing needle at 12 o'clock or 1 o'clock. So once we have figured out our landmarks, we're going to withdraw the bronchoscope to the level of the Murphy eye in the endotracheal tube. The Murphy eye is the side hole on the regular endotracheal tubes. We do that in order to minimize damage of the bronchoscope. That is especially important when you are using a reusable bronchoscope. Once we are in the location that we desire inside of the endotracheal tube, the bronchoscope is in the desired location, we will start withdrawing the bronchoscope and the endotracheal tube as a unit until the location that we want. As you guys are seeing, I am applying some force from the outside at the level of my incision that is being transmitted into the trachea. That is helping us to figure out where we need to stop withdrawing the endotracheal tube. As we remember our anatomy, we are withdrawing the endotracheal tube to the level of the cricoid cartilage. That is very, very close to the vocal cords. The vocal cords are just a couple of centimeters above the cricoid cartilage. So you need to be very careful. Communicate before that with the person that is assisting you withdrawing the endotracheal tube. You do not want to accidentally lose your airway. So just withdraw your ET tube slowly, so you don't have any problems. So once we found the perfect location, we're going to grab our introducer needle and keep it midline. We're going to place it. After that, we're going to tilt it down and we're going to put our gut wire, as we can see here on the video. Once the gut wire is in, we're going to remove the needle, and then we're going to use the punch dilator to make the first dilation. When you're using the punch dilator, you're going to use a little bit of force, and you will need to twist it slightly in order to get it in. Once the punch dilator is in, you are going to use the blue Rhino dilator. The blue Rhino dilator is going to have a skin mark. It's a black line that is going to tell you how deep you should go. After you did your dilation with the blue Rhino dilator, you are going to insert the trach that had been already preloaded with a soft dilator. Once your trach is in, I usually at that time I will inflate the trach balloon, and I will ask my assistant to put the bronchoscope very quickly to the trach to confirm that we are in the airways. As we can see it here, we are confirming we're in the airways. We're having a good location. I will place the inner cannula and connect the trach to the ventilator. At that time, I'm asking the respiratory therapist if we are getting good volumes on the ventilator. Also, at that point, the ventilators have been already restarted, and that kind of concludes the most critical part of the trach, re-establishing the airway. At that point, I ask also the respiratory therapist to keep holding the vent connection, as a trach can accidentally be dislodged until that trach is secure. I usually place 4 sutures. Not everyone plays sutures. I think that they will give me an extra safety net to prevent dislodging of trach. I keep them for 5 days. At that point, the track is for the most part mature. If you decide to put sutures, just make sure that you don't make it super tight, as they can give you some pressure ulcers. Once I finish with the sutures, I'm going to go ahead and remove the our sterile field, and I will put the trach ties. You can use your Kelly's to help you to get them in, and also make sure that you don't place it too loose. You should be able to put one finger on each side. That is how tight they should be. And finally, you guys are going to see me placing a unfolded 4x4. That's a trick that I learned during training, and I think that had helped me quite a bit. Is you pack your trach, that is going to prevent that you have minor bleeding from the superficial incision that you had made, and also is going to help you to prevent pressure ulcers. And at that point, we conclude the placement of the tracheostomy. I want to take a second to thank a couple of people that had helped me with the procedure, Dr. Lucas Pitt and Dr. Louis Satterwhite. Thank you for all of your help, and I want to wish you guys good luck during your training, and thank you for give me the opportunity to make this video. I want to thank the AVIP